Hey, welcome back to the Vitality Code podcast, everyone. I'm Dr. Jason Farrah alongside my brother and co host, Dr. Jeffrey Farrah. What's
Yep,
up, my
yep.
man?
What's going on, brother?
Got another one here for you. How things in Tallahassee?
things are rocking and rolling. Looks to be a beautiful day outside. I'm ready to get out there. Might go do a little horse riding today.
So is it cold out? Those nips going to be.
Yeah, it's a
Gonna be
little cold,
cutting-
probably 50s.
Yeah. That's
I
not
bundled
terrible.
up in my Carhartt, so I feel like one of the boys, one of the crew.
Yeah, you can wear your
trendy
cowboy hat?
now. I don't wear hats. I can't.
Oh, that's right.
All caps hats. Doesn't matter. I want to wear a cowboy hat. I want to feel the part. I want to do some chaw. I want to wear a hat, but I don't like them.
Because?
They bother my head. They're just too tight. I don't like the way they feel. It's a sensory issue. I just don't like it. It's hot and sweaty. I can't wear cool caps or baseball hats. None of it.
They bother the dome, huh?
They do. It's a well-shaped dome, though. To be honest, it's quite round and symmetrical. But does not like hats.
That's one that you want to show off.
Yeah, but I'm worried about cancer on my head. It's always exposed. When I say just throwing caution to the wind, saying screwing it.
Wow. A little, it's your little photosynthesis receptacle up there.
It keeps me going. I saw in my dermatologist's office there was a sign that said 80% of the skin damage is done before you're 20. So I said, all right, screw it. I ain't got to worry about it. It's all been done.
Yeah.
So
fair enough. Well,
before we get rolling, what were you going to ask? Go for it.
No, go ahead. I was going
to say a little snippet or a little graphic to show you. Producer Nick found this for us after our last talk that I wanted to show you. Do you have that that graphic on the Cleveland Clinic, Nick? We were talking about men's health and how a lot of men that I run into don't know their family history.
True. Yeah. Wow.
So 77%, according to the Cleveland Clinic, where they're getting this stat from, don't know their it says complete. So that's whatever that means. The family history regarding neurological issues. 77% of men, 64% on cancers.
Jeez,
so that seems high. I don't know. I don't know what it is for women. We found some preliminary stats that those numbers were half, but.
So women are better, and there's somebody studying about how much.
They're always better, aren't they? That's what I'm told in my house, as I'm surrounded by them.
Well, they must be talking to the women in my house because I'm told the same thing.
Well, you're not outnumbered, though.
Thankfully.
Yeah, my GM at the gym, she's a female, and I was lamenting, like, my house is full of women. My gym, all my trainers are women, and I was like, geez, killing me. And she's like, well, I think we can find out who the problem is here. It's you. You're the one who hired us. It's not like us. It's like we just showed up out of the blue.
Yeah, what's going on?
Dang it. So there's something about me.
But you've hired 2 male chiropractors.
That's true.
So let's give you some props. Not like
give you some props. Yeah.
Well, what
Charlie's
about the
Angels?
Jeffrey's Angels. I think I see an Instagram post coming on. So what about breast cancer in your BHRT practice? Speaking of women, how are you approaching those patients?
I think it's probably the most common question I get asked. There's concern, whereas maybe if men aren't aware of their health history, I think women are more, and it's a concern for them. So I bring up the Women's Health Initiative, the study. I bring up the knowledge that I know about BHRT and the risks of causing cancer, exacerbating cancer. We talk about mammograms. We talk about diagnostics. But as far as I understand it, and maybe I'm going to get educated here, there is no causal link between BHRT and breast cancer. And again, I practice out of
Go ahead.
I was going to say I practice out of a motto. I don't stick my head in the sand and be cavalier, but I'm not scared of everything. So I try to be a middle of the road practitioner. So what was your follow-up question to that going to be?
Yeah, I mean, I think, I think that's the issue here. Like, It's tough. I mean, I don't think it causes it, but it's obvious.
Could there
that,
be an environment that's present that the BHRT influences 100%?
Yeah, it's because we know that there are. So the breast sits on the anterior chest wall above the pectoralis, which is above the quote unquote rib cage, or the bony apparatus of the chest. It's broken up in the female breast lobules, and then leading to ducts, leading to terminal ducts, going to the nipple, and the purpose is milk production. Most cancers arise in the lobules and terminal ducts, and in general, you can think of there's lobular, there's ductal, there's lobular carcinoma in situ and ductal carcinoma in situ, and then you have to talk about which are really cancers or markers of cancer. And these are way beyond the scope of this podcast, but breast cancers in general, if they are truly a breast cancer, you think about they're classified, among other things, they're classified by the receptor positivity they may have on their cells, the estrogen receptor positive, progesterone receptor positive, etc. And so there clearly is an influence, right, on the growth of these, and then that dictates the therapeutic neoadjuvant or adjuvant therapies, mostly adjuvant, that you would then take after treatment of the breast cancer. So an estrogen receptor positive, it may be partial or full mastectomy, followed by chemoradiation, right? So radiation, and then the chemotherapeutic agents, depending on the type of cancer and personal factors and spread and different things, may include something to modulate estrogen, for instance, if it's an estrogen receptor positive. But we know that there's no cancer that, in my understanding, which is pretty decent in this subject, is that there's no correlation, certainly not causation, of testosterone to breast cancer. So when you say BHRT, are you talking about testosterone, or are you talking about all three hormones?
Good question. Yeah, I say hormone replacement to my patients, and I say we may pick and choose which of these three, all three, one, two of them that we use based on your level of risk tolerance, based on your family history, based on your personal history. And so BHRT is generally an option for most women. It may not look the same. So I guess I was speaking broadly, but yeah, sometimes it's testosterone only. Sometimes it's testosterone, progesterone. Sometimes it's all three, but there's usually an option in that category that's available to most women.
Right. So if somebody comes in symptomatic and they're premenopausal, they're not postmenopausal, and they don't have estrogen specific symptoms, one of those may be flushing, although testosterone can sometimes help with those vasoactive symptoms rather. One may be vaginal complaints of vaginal dryness, vaginal lubrication, vaginal health or thinning of the vagina, those types of things. And estrogen, way more so than testosterone, obviously will help those. But let's say they're outside of that. It's more brain fog, energy levels, libido, orgasm, achieving orgasm, or those types of things. And it looks to be, and then you, especially if you test them and they are low in their testosterone, maybe they're perimenopausal, something like that, and you don't think you're going to need to, or or the patient wants to introduce estrogen into the replacement therapy, program. A lot of women still, I found in my clinic, are suspicious that testosterone could cause or contribute to cancer. True, or so do you find that to be the case also? And then if they are suspicious of that, what do you tell them?
I don't know that I find that. I think most women are attuned to the term hormone replacement causes cancer. I don't know that they have parsed that out to think testosterone, estrogen versus progesterone. I think there is an understanding that estrogen is related to breast cancers in my female patients, but I haven't specifically been aware of patients saying that they are also suspecting testosterone to cause that. What I tell them is that, as far as I know, the research that I've read, the understanding I have of testosterone replacement, there is no causal or correlation risk for testosterone replacement from BHRT and breast cancer.
Right. So I agree. And then if you look at lifetime risk, this is outside of genetic risk factors like BRCA1, BRCA2, other genetic risk factors, familial, germline mutations, etc. It looked like cancer.gov said, looking at age 30, you have a 0.49% chance of diagnosis of breast cancer. Age now increasing by decade all the way to 70, it goes 1.55% or 1 in 65. By age 50, 2.4%, 1 in 42. Age 60, 3.54%, 1 in 28. And by age 70, 4.09%, 1 in 24. Okay. Those numbers will not be altered by testosterone whatsoever, nor is there any causal or correlative link for testosterone causing or making cancer, breast cancer grow, things like that at all. In fact, testosterone can help reduce the risk of getting breast cancer or decrease breast cancer recurrence.
It's used in treatment of breast cancer.
In some breast cancers, androgens are used in treatment. There was a 2012 study that looked at breast cancer recurrence in estrogen positive patients. Those women who had breast cancer treated, and those breast cancers were estrogen receptor positive, and they looked in the adjuvant setting for recurrence, or after they had their therapy completed, their recurrence, and what lowered the risk. It looked like the best way to lower risk in that study, for instance, was addition of testosterone therapy and Arimidex, or testosterone therapy and Nolvadex, depending on your menopausal or non-menopausal status. The rationale, and this makes sense, is that testosterone is protective in the sense that it competes for estrogen at receptor sites, right? Suppressing breast cancer cell growth and activation by estrogen. So testosterone is not going to do that to your breast tissue. Estrogen will, but they're going to compete for similar sites. Also, there's a theory put forth, and it makes sense, that testosterone is usually protective against many forms of cancer because of the effect on the immune system. So it helps to stimulate T cell production and activity and stimulate the immune system in general to fight cancer cells, which is your natural inherent ability, your body's natural inherent ability to fight cancers in small microscopic forms, so that they don't go unchecked and grow into cancers. With decreased immunity, you see rising cancer rates or incidence rather, and it is thought that testosterone will reduce those rates or incidence rather by stimulating the immune system. So for women worried about breast cancer with testosterone replacement, that there should be no worry at this point. In fact, if a woman has breast cancer, even active breast cancer, testosterone is not contraindicated. Period.
And I talk to women about sometimes the lifestyle implications. If you feel better, move better, more motivated, better relationships, more muscle mass, there's that halo effect again that can be positive in many hard to measure ways that can be protective of all sorts of diseases. And so while we don't practice out of fear mongering, or we don't practice out of just throwing caution to the wind, there is some validity to the fact that if you feel better, function better, perform better emotionally, mentally, and physically, you're going to have a protective measure for your health overall. So there's a big part of that to microdosing testosterone replacement in females.
Right. Microdosing. What did you mean?
Well, I use that in comparison to males, because I think if you typed in testosterone replacement females, you Google, the way Google works is nobody cares about measured responses and boring nuance. They the cool thing is the crazy thing that happens, so that gets clicked on and then gets clicked on and then goes up to the top and top and top. And so sometimes those Google top answers aren't necessarily the most rational answers, the craziest ones, because I don't really want to know about the nuance boring news. I want to know about the crazy thing that's happening, and I'm going to read that, so that gets pushed up top on the health side.
Yeah, agreed. And then the nuance matters, though, right? So we use supplements like diindolylmethane in our clinics. So those come from cruciferous vegetables, naturally found, naturally occurring, and these
also known as DIM.
DIM, right, comes from a parent molecule, endocarbonyl 3, but DIM's way more effective and better for you. And this helps prevent the conversion of estradiol to estrone. And commonly called old lady estrogen, which has been implicated in cancer.
I've never heard that.
Yeah, old lady estrogen, and it tends to have a negative effect on a woman rather than a positive in all end organs that it reaches, and not, namely here the breast, and potentially stimulating more potent and or the stimulator of breast cancer cells than its cousin or sister, rather, estradiol. And then there's estratriol when you're pregnant from the placenta. But at any rate, now what about a woman? So women that don't have or do have breast cancer or have had breast cancer, all three. I mean, they can have testosterone, no worries. How do you approach supplementation with estrogen?
I'm probably, probably. I if a woman has active breast cancer, I won't treat her with estrogen. It's just not, I feel like, in my lane of expertise, whether or not it is medically appropriate, whether there's a ample risk that the patient is willing to take on, or no risk and they're fine with it, and it's just not something that I feel is in my lane of expertise enough as a physician to go down estrogen. That's been the way that I handle it in my clinic to date. Not to say that it won't change, but that's how I handle it right now.
I'm somewhere similar. I think it's a little more nuanced for me. You talked about the World Health Organization, WHO studies, and eventually the nested studies or the subgroup analysis that say, wait a second, turns out it's the synthetic estrogens and namely synthetic progestins and progesterones that are causing the problems with blood clots, DVTs, cancer, things like that, uterus and breast, that are the culprit here, the smoking gun. Not so the bioidentical hormone replacement therapy with bioidentical estrogens. So that's one. The next thing was that there has been conflicting studies on postmenopausal women with breast cancer risk or who have had breast cancer using estrogen for postmenopausal symptoms, right? And so there was I can't remember the name of the study, but there was a famous study that came out that said it increased risk. And then there was a Stockholm study that came out and said, no, it doesn't. Most recently, I saw there was a 2022 observational cohort study out of, it was a Danish study that looked at vaginal estrogen therapy versus menopausal hormone therapy, MHT. So they called vaginal the VET versus MHT. And actually, there was a small increased risk of maybe vaginal estrogen therapy, which was odd and a little bit counterintuitive, but not so for the menopausal hormone
Interesting.
therapy. And that is, when I say no effect, that is in terms of it did not promote significant morbidity and mortality or breast cancer recurrence in people with low-grade estrogen receptor positive breast cancers.
Yeah.
And I found that to be particularly appropriate because I have a patient who came into clinic who was 10, 15 years out from a breast cancer. And when I say breast cancer, I'll just tell you she had estrogen receptor positive DCIS, ductal carcinoma in situ, and underwent partial mastectomy, followed by adjuvant radiation therapy, followed by, there you go. You brought it up. That was the Danish study. Excellent. Followed by, if you scroll down there, let's see. Nick, scroll down to results. Neither VET or MHT was associated with increased risk of recurrence or mortality. A subgroup analysis revealed increased risk of recurrence, but not mortality in patients receiving VET with adjuvant aromatase inhibitors.
Interesting.
Interesting, huh? So these lower grade cancers. This woman was 10 years out and had chemoradiation in the adjuvant setting. She had specifically, I don't know if she had Nolvadex or she had like tamoxifen or she had an aromatase inhibitor, which would be based on your age and a menopausal status. But nonetheless, she came in and was very symptomatic. Hot flushes, low libido, weight gain, brain fog, energy levels were depleted, and she had virtually no estrogen and definitively no testosterone. And the question was, what do you do with her? she had dyspareunia and vaginal dryness. So we had to have a long discussion. I mean, the testosterone was obvious. She could definitely have that. In fact, would lead to lower breast cancer recurrence. On the one hand, we thought, and not that taking estrogen with the testosterone or either one by themselves will literally cause you to just drop weight off your body, but it definitely will promote a better metabolic functioning of your body. Definitely will promote better glucose homeostasis, will promote weight loss and increase in lean body mass. And the thought that we kind of mulled around out loud was, there is this. Now, if a patient had active breast cancer and it was estrogen receptor positive, like actively being treated, I don't think I would give estrogen. I mean, that just seems completely ludicrous and nuts. Although, it'd be interesting to see what patients would say that are suffering from those menopausal symptoms that are going through that, And
Well, we talked about this before. There's the patient bill of rights, but there's also the doctor bill of rights.
Well, good
and
point.
so, I tell patients sometimes when I'm faced with a decision that maybe I'm not comfortable with, I don't always say, like, you shouldn't do that. I say, like, I don't know if this is the right decision. I don't know if I'm the right physician to handle this monitoring and management for you, because I'm not as comfortable as I want to be. Maybe in this situation, in this specific topic, I'm a little more comfortable on the prostate side of things. If we want to, juxtapose that cancer situation, prostate issues to breast issues in hormone replacement, but I'm a little less. I'm just not comfortable, and I tell patients, you don't want to be the first one that I manage and treat.
Right. And so, this lady, for me, for active breast cancer, it's a no-go. Testosterone, fine, but estrogen, no. Now, in this lady, she was willing to, she very much desired to have low-dose estrogen added to her regimen for specific reasons that testosterone would not likely help very well, or very much, rather. And this is how I approached it. I felt we had a very long discussion, very open about the risk, benefits, and alternatives, very candid. She was willing to absolve us of all the risk and take the risk upon herself and document it as such. I did not feel in my doctor's bill of rights, speaking from that side of things, and the way I think about it is, you don't have the right to put me in a situation where I feel like I'm putting you at undue risk, right? That's you should never ask a doctor to do that. That's crazy. It's unethical. I don't feel like I was putting her at undue risk adding low dose bioidentical hormone replacement therapy in the form of estrogen to her for the reasons of the Stockholm study, the observational cohort study that we just showed, and the fact that she has symptoms and there was indication she was 10 years out. She had a low grade DCIS with estrogen receptor positivity, had chemoradiation, was getting regular mammograms. That was something I insisted upon. And this is where you might say, you might consider, I would not order it, but I would maybe discuss it with her oncologist and or breast surgeon, maybe an MRI for monitoring to make sure you're picking up subtle cancers that maybe radiology could not identify.
Yeah, I was told by the oncologist for my wife that mammograms are not sufficient. She's BRCA positive, and the oncologist said, like, there's 0 point in you doing mammograms. They're not diagnostic. They're screening tools. You need every 6 month MRIs.
Yeah, and so clearly, a person with a personal history of breast cancer, even more risk than the average population. All right, and then someone with a BRCA for sure. So perhaps that's something we should approach in this woman. But again, if I felt okay coming alongside her, should she be willing to incur the risk, which she was, given the data that's out there now. Observational cohort studies are low quality data, but they're better than no data, and they give you some precedent and they suggest some signal in the literature. Certainly if it was such a profound increase in cancers from hormone replacement therapy in menopausal women, there should be some kind of signal in literature to state that, especially in an observational cohort study, but there isn't. Now, again, it doesn't prove causality, and it's not it's not the highest grade evidence at all, but it gives you some kind of preface to work from. So in those scenarios, I'm okay. So that's how I think in the woman who has low grade estrogen positive cancer, it gets a little tricky, and you're worried about recurrence. it gets a little tricky, but there is some precedent along with the patient's autonomy. If you feel that you're absolved of the risk and or you feel comfortable in facilitating that to treat in that scenario.
Yeah, I think. Yeah, I think my trepidation, if I'm honest, it comes from my biases that was established by the women's health study. And even though we have come to realize that that data was not maybe what it was reported to be exactly, it's still hard to shake the influence of that. And I think a lot
Right.
of physicians, and if I'm just honest about it, it made me, it because the beginning years of my practice, not in hormone, were jaded by that precedent. And so it's hard to let go of that. And so I'm just, I'm still unfortunately jaded by the misinformation, you could say, of that study. Just like I think I see in general primary cares and the prostate cancer risk, right? They're like, oh, no, it causes prostate cancer. And it's like, no, I'm not sure which data you're talking about. You know, like, oh, the study from the 50s, that was a terrible quality study of like N of 2. But so I'm still a little bit jaded by that. And so if I'm honest, it just makes me a little cautious, even though I know now differently. But what do you
I
think about that? Go ahead.
I agree. And the problem is that in medicine we get dogmatic, in science we get dogmatic, and those things stick around for long periods of time and create biases. But those biases and dogma rather, for me, come up against the reality for patients. And I've had recently 3 women, in fact, come into my clinic within the last month that are in tears about their symptoms and the reality that they only live once and people want to have a higher quality of life. Their quality of life is poor. And like, what are they doing? Are they just kind of existing to exist? And
Yeah.
my whole world now becomes trying to avoid this cancer, and it's dominating my life rather than me taking control and living and having a sexual relationship and a close relationship with somebody and living life to the fullest. And breast cancer be damned, and I can't help but notice that, and I don't want to ignore it, and I want to be sensitive to it because it's so obvious to me after years of surgically treating cancer and seeing the secondary, the adjuvant chemotherapy and the different things that people go through with cancer. I don't know. You can't ignore that because
Yeah,
you
I
see
agree.
people come and go and die of things, and you think, my gosh, what are we doing? Are we really helping people, or are we not? I mean,
I strongly believe in patient autonomy from a personal standpoint. I tell patients sometimes that butts up against what I'm, like it doesn't necessarily matter in certain situations. Like, I can't cause you known harm, and I can't allow you to let me cause you known harm. Those, so, but outside of that, like, I have a wide breadth of patient autonomy that I like to practice in, because that's the sort of latitude that I want to be given. I want to be able to make the decisions that I feel are best for me. And I want to be able to make those decisions outside of I don't want you to make decisions for my life based on what you think I want for my life. I want to know the information, and then let's make that decision together. So yeah, I'm with you. I believe strongly in that patient autonomy. I think you should be able to make those decisions.
yeah.
And you are in a lot of other areas. I don't get why certain areas
exactly.
is like I don't know. It's weird to me when I hear primary cares. The common example I give is primary cares will often say you don't need testosterone, right? And then I look at the patient list and they're on Adderall. And I was like, oh, so you had an Adderall deficient patient and you were trying to bring them back to Adderall equivalencies that they normally had in their body. No, stop. Don't give me that bullshit. Like, you just found this optimization of better value due to your preconceived notions than this optimization that you don't view as better. Like, there's no logical basis for that as far as I'm concerned. So I think again, I like a large latitude, but I tell patients, for me, I'm probably not the best one to take you on that journey. And I think you touched on something, is that I probably haven't butted up against that with a patient base enough yet, because I am sensitive to the concerns of my patients, that I would, if I was met with 2 to 3 to 4 patients of this nature that I was turning away, I would probably My thought is I would bring myself to a, a necessary comfortability to make that decision, as opposed to just saying, I'm probably not the surgeon for you, or I'm not the
Right.
doctor for you. I haven't really butted up against that yet. And so maybe that's part of the reason why I haven't gone down
So
that
you
road.
take it on a case by case basis. It turns
Well,
out you haven't had a lot of cases of it.
yeah, like I no, this is not talking about it, but that's how my semaglutide and tirzepatide prescribing came out of. Is I initially was like, nah, I own this gym. You shouldn't do this for weight loss. That's is my own preconceived notions and the way I would handle it. And I had a patient challenge me on that, and I was like, yeah, you're right. I'm making this out of my personal opinion rather than the research and the data and giving you the information. And when I agreed on to look at the data and look at the research and make an educated decision and prescribe her this drug, I then opened up a whole new avenue that I didn't realize was out there for a lot of patients, a lot of my current patients and new patients who were struggling and wanted that thoughtful information. So maybe all it would need is the right patient to push me up against my ideas.
Right, your preconceived notions and
Yeah.
challenge you on them. Yeah.
But I think it's important for patients to know this for themselves. So, let's talk a little bit about the women health study and the headlines that came out, the quote unquote, and I don't mean this specifically, but the CNN style headlines were like, hormones cause cancer. But when you look at the raw data, you get a very different, nuanced approach. And there wasn't necessarily, as I understand that study was looking at cardiovascular benefit, changes in cardiovascular and protective mechanisms from hormone replacement, and they weren't seeing the signals that indicated that there was going to be a significant, in their study cohort group, benefit in that avenue, and they were seeing some potential signals for cancer related issues, and so they stopped the study for that. There was no real, they didn't say it caused cancer. That was sort of the running of it from the sort of reporting of it. Do you
Yeah,
have any?
and then subgroup analysis showed, look, you can't lump all these in together.
Mm-hmm.
You need to look at the actual medicines that they were getting. Were they synthetic? Were they not? And were they progesterones or estrogens? Were they not? What were if you do a multivariable logistic regression analysis, what's the independent risk factors truly? And the study just came out to be flawed. And the
Yeah,
analysis,
my
and the
takeaway from
analysis,
it is I don't prescribe synthetic estrogens combined with synthetic progestins. I don't do
absolutely not.
that.
Yeah, absolutely. And I don't prescribe synthetic anything. Period.
Mm-hmm.
For women. But it was so funny because the upshot of that was that ACOG, American College of Obstetrics and Gynecology, changed to no hormones for menopause to, okay, you can have 5 years of hormonal
Yeah.
therapy after menopause for menopausal symptoms. It's reasonably safe to do so. So I thought that was interesting. But it just tells you that, again, not all research is created equal. There's lies, there's damn lies, and then there's statistics. So you got to really, as a practitioner, look at how the study is created, how it's executed, and how it's interpreted. Like, for instance, I'm sitting here talking about this observational cohort study, this Danish observational cohort study. Well, it's got a large number of patients. That's good, but again, the study design does not lend itself to be super high quality, practice changing data. It just, I think it increases the amount of data that supports treating folks with with a history of low grade breast cancer, estrogen receptor positive, with hormonal therapy in the adjuvant setting for menopausal symptoms. But it doesn't absolve the risk, and it kind of suggests that it's probably okay. And that's
Yeah,
all
it's
you can
part
really
of a
take from it.
larger picture, right? And then also I think
Right.
about how you practice, right? I don't practice out of this sole paradigm of what the research says is what Jeff does. That's I practice out of this paradigm that there's a decision in the middle that needs to be made. Research covers this, and what does research influence? What does it say? There's the patient's needs,
Right.
wants, desires that kind of intersect here, and then there's my experiences and my influences and what I see and how I see it play out that interferes or that intersects right here, and the answers between all of those. So just because it's research or evidence based does not mean we are practicing out of the what does research say, and I always do exactly what one research article says. You, I don't want to go down any rabbit holes, but I think COVID brought regardless of whatever side of the fence you were on, brought to light the difficulty with interpreting the data and interpreting
God, yeah.
information. And as simple as this sounds, and as trite as this may be, I juxtapose this sometimes with patients. As I say, you have the top doctor in America who could not tell you whether or not you should wear a mask or not for a respiratory illness.
Right.
He didn't
Or
know, right?
supposedly, yeah.
Supposedly, but he didn't know, because then he said, well, I did know, I just lied to you. So that's worse. I purposely misled you. So if you're going to tell me that I'm going to make decisions out of the hierarchy of all research, and then I'm going to come back to you and say, well, the top doctor, who I've been told to believe is the top doctor in the United States, there's a respiratory illness, and he does not know if you should wear an N95 mask, and he flipped his answer and flopped his answer. That to me is like an example of for me, that's an influence of the research. And so, like, I take that information to influence my decision, but I'm not solely relying on our research study by our individual at our and research is being jaded. The professor, or the president at Stanford, I think it was last year, got in trouble for plagiarizing, specifically research studies. So, like, let's be honest here. The research is only good, just like computers and AI, it's only as good as information being put in, and the research is being influenced and performed by individuals. And this idea that research is this ultimate gold standard that is never flawed is false, but it does influence my decision making, and I do need to be aware of it, even if it is a potentially flawed, as is my experience down here. I understand that same paradigm. Like, I may think I see something specific, but I may not be seeing what I think I see. So that's why it's influenced by multiple avenues. But to bring it back, I feel comfortable with research. I feel comfortable with my patient practice. I feel comfortable with my patient's needs and reporting of outcomes, that testosterone is usually always on the table. And then progesterone and estrogen are usually on the table for most instances. I would say I don't do estrogen for I exclude estrogen for women less times because of cancer risk, but more times because I don't think there's going to be a positive subjective outcome. So that's probably the more common thing that I butt up against. Like, say, a pre-perimenopausal woman. I had one this week who was having some mild hot flashes, maybe some mild genitourinary system issues, but was still ovulating, still having her period. When I pulled her estrogen, it was still pretty robust, but had some estrogen symptoms. Her testosterone was 3. I was like, here's why I don't want, here's my opinion based on, you have some estrogen symptoms, your estrogen pure is robust, your FSH is still low, you're still ovulating. I don't think I'm going to put estrogen into your replacement right now. Maybe at some point it will be on the table. Let's start with just this. And see what that influence is. That's the other thing I think sometimes you don't have to have the exact recipe right off the bat. Right? I said, let's start with some testosterone.
And the recipe changes over time.
Yes. I said, let's start with some testosterone now. Let's see how this, because what I heard from you, correct me if I'm wrong. I say this to my patients. Here's what I heard you say, and here, correct me if I'm wrong, that A, B, C, and D were your top 4. Those are all testosterone majority influence. Number 5 and number 6 were more estrogen type symptoms. So if I did just testosterone right now, it would take care of your top 4. Would that be enough for you? And then we see if estrogen is appropriate later. She's like, yeah, that sounds great. So that's generally how I lay it out for patients. And I laid the upside downside to her. I said, well, if I miss the mark and I should have given you estrogen, it won't make you any worse. It just won't correct those symptoms. And you may get a little resolution from the testosterone because it'll aromatize at the tissue level. If I'm right and I give you estrogen, you have a negative response. Here's the negatives subjectively that will come from that. And she's like, yeah, I don't want those. Those aren't trade-offs, right? And so we decided to do just testosterone, but that had nothing to do with her cancer risk specifically. That was just a very subjective, nuanced approach based on her symptomology.
Yeah, and that's an easy platform. It's a good platform into which to interject similar analyses of cancer specific risks. And so,
correct,
in a similar fashion. And I like that. Yeah, that's a good tip. So in general, again, women don't need to fear testosterone therapy for breast cancer. In fact, it may reduce chances of getting breast cancer, and certainly does. There's certainly data to suggest that it decreases breast cancer reoccurrence risk in estrogen receptor positive cancers.
Also, I've seen some data that the earlier you start hormone replacement in this, the better off you are, and the better off your outcomes are. One of the things I remember from the World Women's Health Initiative study there was, let me see if I can get this correct. The women who are postmenopausal 10 years plus, right? So they have had no hormones, no hormone replacement, have been menopausal for 10 years plus, and then start hormone replacement. There was a slight uptick in cancer detection. And so that's a subgroup that I think and my thought on that is maybe potentially you are finding the women and you're getting a diagnosis that was maybe going to be delayed. Because now we're dealing with a median age of 51. So if we use the median age of 51 for menopause, you go 10 years plus, they're 61. They're starting hormone replacement at 61. And their lifetime risk is going up because they're getting older. And so maybe you're butting up against this cohort of women who were going to get a diagnosis, but now they're beginning hormone replacement. There's a lot of things that could go into that, but that's another subset of women that I take a little caution with.
Well, you got to be careful there too. You wonder if it's a type 1 or type 2 error, or is there a true and unrelated, basically? Like, true, they were that subset. True, there was an uptick in cancer, and they happened to be on testosterone therapy, but was it causal? I don't know.
100%.
Yeah.
That's what I'm saying. Like, was it just that? I mean, there's lots of things I can think of off the top of my head. Did they just now begin to start going back to a doctor and that doctor said you should be getting regular mammograms, let's do some hormone replacement, but you should be doing this, and they weren't doing that, and then maybe they started it and they found them. Maybe there was I think a lot of different potential things that happened, but I just report the data to the patients and we talk about it. We interpret how I view it, and then we kind of make a decision together.
Yeah.
Shared
decision making. That's the way to
go. So that's one cohort that the women who are 10 years plus postmenopausal.
And you're talking about initiation of testosterone?
No.
Estrogen?
Again, yeah. So again, that would be an estrogen. Yeah.
Yeah, and then of course, you got to see what their symptom complexes are too. Maybe there, like you said, there isn't even an indication or a need for the estrogen, or the majority of their symptoms are testosterone related. And let's go with that first.
I think also for my female diagnosing and treating, I've started to appreciate estrogen more, as opposed to being scared of it more. And sometimes there is a milieu of symptoms that are they're outside the textbook ability to say, this thing is benefited by estrogen. It's just sort of a whole package for a woman that is somehow betters her results. And not to sound esoteric, but because she's a woman, this estrogen is part and parcel of her womanhood. And I'm having a hard time explaining it, but they just seem to do better a lot of times if there is some estrogen involved.
Well, everything
that makes sense.
Makes complete sense if you think about even from a genomic perspective and your XX. I mean, it's obvious, right? That form and function. I mean, anatomy and the phenotype, the genotype, as and then expressed as a phenotype. If you're a female and you had a massive amount of these hormones during development, your end organs, your brain, for instance, and different things are going to form under the influence of those hormones. It's no shock to me that would be the case, that then repleting it will tend to make them a little bit better because, again, like you said, for them specifically, and what is optimized for them from a hormonal perspective includes some amount of estrogen. I think adding things like the DIM so that you don't convert to estrone. I think making sure that their testosterone predominant, so that helps to stimulate the immune system, compete with estrogen at the receptor sites of the breast tissue, for instance. Those types of things are small but smart ways to potentially protect them. If they have a uterus, making sure you add progesterone to prevent abnormal and unchecked uterine thickening and potential for uterine cancer.
For sure.
Things
I
like
explain
that.
it to
So,
all the people. If you're doing estrogen, there's a uterus, you're doing progesterone. And that progesterone, remind you, has to be oral to achieve that 5 nanograms level for proper uterine protection. I explain that to my practitioners when they start this hormone replacement journey as a practitioner. Make sure you're using oral. And I prefer a bioidentical oral.
Yeah, micronized or dental.
Micronized, yeah. There is a name brand of that too. Prometrium, I believe is the
really?
name brand.
I didn't know that.
Yeah. Sometimes insurances don't cover it, but if you have someone who's cautious of the cost, uninsured cost of, it's not, I don't know what's considered expensive, but it's not a super expensive progesterone micronized from a compound pharmacy. It's not thousands of dollars a month or anything. It's not a expensive medication.
But still, knowing that might be better. It might be you might be able to get them the compound at a cheaper price through their insurance. So
yeah,
that's a good one to know.
Yeah. So do you find that a majority of your women, I don't know if you even know this, but just like if you took the average woman, most of your patients on all three, or most of your patients on one or two or one? Like, what does that demographic look like for your hormone replacement females?
I find that predictably, at least to me, the older they are, the more likely they're going to need estrogen.
Yeah,
because and that makes sense because the testosterone in the perimenopausal state, or one of the first signs of menopause, or as you head towards menopause, you're going to lose the testosterone producing function of the ovary long before the estrogen.
Long before. I just looked at the lab before I came up in this, and I have it sat down and had the full consult with the patient. We did a preliminary consult, pull her labs, and her testosterone was 0. Her estrogen was 329. And she's like, I'm still cycling. I'm 49. When's this going to end? And I was like, well, that's interesting to see that.
Yeah.
I don't know where she was in that cycle. So, but that's a pretty robust estrogen compared to a testosterone of 0.
Well, that would be, it would be abnormal if it was anything but mid-cycle. That 329, that's
a big one.
Very high. That would still be within the normal for mid-cycle. I don't know if it's luteal phase but basically mid-cycle.
Yep.
That's pretty high. Yeah.
Which you would also think if she was building up and ovulating, that testosterone would be at its highest as well.
No, I wouldn't think that. I wouldn't.
Going towards her ovulatory phase?
Mm-mm. If you look at the graph for testosterone, it's almost flat across the entire. This is the whole thing. This is the thing about testosterone, is that the massive.
But it does
spike,
rise.
It actually starts out. No, it actually starts out a little higher in the beginning.
I have to go back and look at that.
Yeah. And it kind of slowly decreases. But remember, at the level of the brain, estrogen induces strong sexual desire. So these big spikes mid-cycle, which not only induce the ovulation of the egg from the ovary, also induce, in conjunction with high but slightly lower than the beginning of the cycle, testosterone, strong sexual urges, which makes sense because that's when a woman is quote unquote most fertile.
Right. Procreation. Supports procreation. Yeah.
Yep.
Yeah. I mean, the testosterone definitely is less of that big giant spike and fall for female.
It kind of slowly
decreases. The dominant hormone for both sexes.
Yeah, or their lifetime,
it's testosterone, which is quite interesting. A lot of physicians and patients don't know that.
Yeah,
I still find it interesting to talk to. Not interesting that women talking to women about testosterone is generally not in their window of expectations, as well as talking to men about estrogen is not always in their window of expectations.
Yeah, exactly. Yeah,
but both are important for both sexes.
Right. I find that women are well, again, probably biased by my clinic or who's coming in, but it seems like over the years, women seem to be a little bit more informed of that. But in general, yeah,
I would say so.
Yeah.
But again, I don't think gosh, I wish I saw that stat. There was a good clinician out of the UK and she had some good stats about women on any form of hormone replacement. It was really low, really, really low. But I think it's sometimes hard. We have selection bias, right? You don't come to my clinic and ask about hormones unless you've seen something, read something, heard something. And so by proxy of that, it's probably from one of the people around you. And then you refer those people. And so it kind of creates this selection bias, all the same kind of people coming in. And so it definitely seems like it's much more common. I think it's more common than it was in the past, but I don't know how exactly
But
prevalent it is.
there's a societal bias too against women, and it bothers me. I mean, because let me say this: if you have hot flushes and heat and cold intolerance, some obvious menopausal things, oh, okay, yeah, go get some estrogen. But no one talks about testosterone. Oh, you have a poor libido. Well, yeah, I guess that was always going to be the case. I'm married. I'm getting older. That's just the way it is. You don't have the need to be a high driving performer who wants to be able to be focused and high energy. And I was talking to a female dentist. She's a pediatric endodontist, and I mean it's a subspecialty, right? And she was talking about her inability to be focused, fatigued in the clinic a lot, wanting to perform at a high level, and it's crazy. It would be very natural to say to a male CEO or high performer, "Oh yeah, you got to get some testosterone." It doesn't seem to be that natural for us to celebrate women doing the same thing. But why shouldn't women? Why shouldn't your daughters? Why shouldn't my daughter, when she's of age to need that, be considered? That's important for her too. It's bizarre. Why should a woman
I
not
agree, but it is.
be able?
It seems to be
Yeah,
quite
it's a
common.
prejudice or something. Societal construct. But and I think that lends itself in a problematic way to women getting hormone therapy prescribed to them.
Yeah, I
You know,
think so, and I think
oh, your FSH is normal. You're fine. Did you check my testosterone? No. Why would I
right.
check my testosterone? I mean,
Yeah, that's the common one I see. That my hormones were checked. All right, I'll go pull those labs, and it was an FSH and an estrogen.
yeah.
That's the most common one. Yeah, I think that's changing for women too. There's a lot of societal differences. One of the more common things I explained it once to this patient, and she explained it to me one time, and she had a milieu of symptoms, right? And they seemed in her brain to be very unorganized and not related. She's like, I just feel like I got this brain fog. I'm tired. I'm moody. I've lost my libido. I feel like I'm getting fat. And she's like, I feel like I'm going crazy. And when she said that last word, that last sentence, I was just like, I wonder if maybe a physician who, and I'm going to just kind of opine a little bit, but hears that and heard about her talking, he's busy, she's busy, and they heard it. And then the last phrase is, I feel like I'm going crazy. Because another common script I see is like a Zoloft,
I know exactly.
I was like, yeah, that makes sense. You would feel crazy to a sense because you're like, this doesn't make sense. My libido's off, my energy's off. I have brain fog. I'm agitated. I have hot flashes. Those don't seem to mix at all. They're all over the board. This is making me a little nutty. And then maybe when you relate it to your physician, he's like, oh, honey, it's okay. Or dear, or, like in addition to those other symptoms or reasons societally you talked about, maybe the physicians are just latching onto that last part of it, or the way that an emotionally attuned individual would maybe talk about symptoms instead of being cut and dry. I'm having this symptom. I'm having the symptoms. They talk about how those symptoms feel to them, and that gets perceived differently.
Oh, absolutely. It's not, they're not walking in and saying, I'm unable to achieve climax and I have vaginal dryness and low desire, even though I want to have better desire. It's all these other things. And then, I don't know, I just feel like I'm going crazy. And
Yeah, I
because the
think when I
person
heard
doesn't,
that, when she said that last phrase, I was like, that makes sense.
they almost feel, and that speaks to, I think, they almost feel guilty for feeling those things. Um, this is so abnormal. I must be, this is so abnormal. I shouldn't feel this way. So therefore I must be crazy. Not, oh, I live in this Western society with all the different endocrine disruptors, I'm exposed to all my life, and I'm getting older, and no, this is actually normal, and I need to be evaluated for hormonal dysregulation. No, the expectation is that you'll power through these things, and that you should, even despite whatever. And yeah, you might be crazy. They almost feel guilty for it.
I was looking on my phone because I saw this post and I wanted to see if I could find it. There's a doctor, Mary Claire, who does hormone replacement on Instagram. I don't know anything about her, but I think she has some good content. And one of the posts that she made was from one of her followers, and the follower said, "I love your message. I've been following it, so I went to talk to my doctor, or specifically, I went to talk to my NP to discuss." And she said the following to me. Told me that the penis will never die, so I need to find a way to wake up my vagina so I can make my husband happy. Um, and then she said, why does nobody care about women? I was like, if that's true that a physician said that to you, that was the patient's recollection on this. Like, it just seems so silly like that. But that, I think, is sometimes the sentiment.
The penis will never die.
Right? It's just such a weird thing to say in and of itself.
The penis will never die. Oh my gosh. You got to wake up your vagina. That's ridiculous. Yeah.
I'm surprised sometimes too by the opposite of that. Sometimes, I mean, I commonly meet with women whose libido is much higher than their men's.
I see that a lot too.
That's not uncommon at all. But that sentiment, I think, is what you're talking about, right? You know, it's like,
oh yeah,
if that statement was true, it's like, good Lord, that's horrible.
And you know why that statement is terrible too is because, in my experience, and with my selection bias, of course, women will say things like, "I have no libido. It's like I just don't care. I don't want to be touched or anything. I just man, whatever." And then I'll say to them, I'll try to probe a little further, but does that bother you? And they're like, "Oh yeah." It's not like they don't want. It's not like they don't want to be like. It's
sure.
You think I just need to wake up my vagina? Yeah, no crap, no shit. Like I want that too. Like, I don't know how to make it happen. Well, turns out there's good reason because you don't have any damn hormones. What do you? I mean, that's how the body works. What do you? I mean, you're just supposed to take your prefrontal cortex and your anterior cingulate gyrus and somehow will that to happen. I mean, and will more hormone production is effing crazy. Like, you know, it's the chicken and the egg. Well, in this case, we know it's the egg, the hormone that begets the chicken, you know, and so trying to do it otherwise is just ludicrous, especially when you can do it safely, cost effectively, and improve your health outcome and health status.
Yeah. And in turn, low risk for the sort of most common thing we're all scared of, which is that most women are scared of and heard about, is that breast cancer, that risk. And there's, you know, at least according to the research, there's little to zero risk from the testosterone. If you were even scared of the estrogen, which is jaded by, you know, subjectively jaded by if you had a family member too, you know, I'm not going to force a woman to do something. But there's three parts to that hormone replacement equation.
Yeah. I think for testosterone, realistically, there's little to no risk. I mean, just very, very, I mean, again, in medicine, we don't want to ever say never, and we don't want to say always either, but, you know.
As to date.
Yeah, exactly. So I think this has been a good discussion about that because folks are wanting to know that, and go out there and get those pellets, man.
Yeah,
feel better.
I have a patient with BRCA2 and double mastectomy and still on testosterone.
Yeah,
so it's a completely reasonable expectation.
All right, man.
All right, Doc. Good talking to you. I'm going to bring some. I was looking through that same page, and there was a lot of response from individuals and at least according to their Instagram handles, doctors and stuff going back and forth, and some of the questions underneath there. So I thought for the next one, similar to this topic, I might write down some of those questions and we would just do a Q&A addressing some of those specific real world questions. If that is accurate based on the Instagram being real world or not. Questions that are out there posed by.
Oh, you're talking about Dr. Mary Claire?
It wasn't her page. I had to look exactly. It was somebody similar to that. It was somebody who was talking about estrogen, menopause, hormone replacement, sexuality, you know, that sort of thing. And there was a back and forth between women who were, or people who were pro and con against hormone replacement down there, and some of the questions and stuff. So I thought that'd be good. These were actually put out what could be surmised as by real people.
So now we're not only fighting bro science, we're now having to find Instagram science.
Yeah, right. The explosion.
Science, yeah.
Bro science.
Jeez, gosh,
I love some good bro science. Hey, we still do rob some stuff from bro science, you know, in the testosterone replacement world. I think.
Give me an example.
I think the some of the concepts in testosterone replacement were pushed by the bro science world when it was demonized by physicians classically. And we can look at some of the negatives and why you shouldn't do synthetics, and we have a test population here, the importance of managing estrogen, not just bottoming it out, not just doing nothing with it. I occasionally have people who come in who are taking testosterone on their own, and their things have happened in their past and yada yada, and they want to get advice. And here's the things I was seeing, and here's what I was being told. And so I think a lot of that bro science, so to speak, laid a little bit of the foundation for where we are now, whether good or bad. Some of the stuff you shouldn't mess with. Yeah, but my blood pressure is good. My numbers look good. Yeah, but you're 25, and what's the repercussions of that going to be when you're 45 for doing those synthetics and things like that?
Yeah, I agree.
So, sister science too, I guess, huh?
That's right.
We'll find out. We'll find what those questions are.
I know. I look forward to it, man. All right.
All right, bro.
Good talking
See
to
you,
you,
man.